Hello, welcome everyone to this week's virtual Global Spine Conference. I have the honor and pleasure to host my dear friend, partner at Northwestern, who is a tremendous surgeon and even a better human being, Dr. Joy Trybula. Dr. Trybula finished her training at Northwestern Neurosurgery and joined our practice. And she'll be sharing her wisdom as well as really excellent pearls on early lessons in building a neurosurgical practice. This is a topic that's extremely relevant and important, especially to those embarking on a career in neurological surgery, finishing up their chief residency or fellowship. So I hope you enjoy this spectacular seminar, and welcome again, Dr. Trybula. Thanks for joining us and accepting to speak at this platform.
All right, thanks, Dr. Dodley. I really appreciate the warm welcome. And as someone who's watched the virtual Global Spine conference, even through COVID, it's been great to see all the videos and educational material that's put out through this conference. So I'm very excited to contribute to that. And this talk is really, like Dr. Dodley said, targeted towards people in training, early out in their careers, even medical students and people considering neurosurgery, just to get a taste of the things that you may learn and encounter when you're starting a neurosurgical practice. So without further ado, I will proceed. So one disclosure is I'm an IRIS consultant, but that doesn't have any conflicts with today's talk. So the objectives are to provide a perspective in developing a general neurosurgery practice, understand the nuances and outpatient management of spinal pathology, and identify some factors in starting a career that can promote your success. So just a little bit of background about myself. I was born in China, Xi'an, China, and immigrated to the United States when I was about a year old. And we grew up for the most part in Indiana. So for those of you who aren't that familiar with the Midwest, it's the state in red, right next to Illinois and Ohio. And I went to Purdue for pharmacy school initially because I was interested in science and biology, and quickly found out that I was more interested in caring for people and patients instead of learning about the medications, actually, and transitioned to medical school at the University of Pittsburgh. After completing my medical degree, I matched at Northwestern with two fantastic co-residents, Aaron Palmer and Dean Karras, and completed my residency at Northwestern, and was lucky enough that actually Dr. Dodley at the time went over to the Western region to become the director of neurosurgery over here. And I was interested in a career in more general neurosurgery with an interest in cranial pathology, and so joined the team at CDH and Del Nor in the Western region. And so my practice really comprises mostly of cranial pathology, traumas, brain tumors, brain metastases, about 60%. And then the remaining 40%, I focus on degenerative spine disease. And so this slide is, I think, representative of why many of us get interested in neurosurgery to begin with. Why people are drawn to neurosurgery is when you think of a neurosurgeon, you're thinking of the complexity of the brain and all the interesting and probably poorly understood elements of how the brain works, and wanting to treat brain pathology. And truthfully, when I was a medical student, this sort of picture was the most exciting to me, is seeing an olfactory groove meningioma and seeing the approach and how to resect it and how the patient did afterwards. And everything was just really fascinating about the brain. But this is really the reality of what neurosurgery is. It's spine pathology. Degenerative spine pathology probably comprises the biggest amount, the highest volume. And this is like, these are all pictures from my clinic over the past few weeks. Cervical stenosis, lumbar degenerative disc disease, radiculopathy, spondylolisthesis, foraminal stenosis, it can go on and on, right, with a number of different kinds of spinal pathology that we see and the presentations that people come in with. And so this slide is basically another representation and more proof for why spine disease is so prevalent in our population. So this is a little bit dated, but it's Medicare data from 2004 to 2018, and it shows amongst this population of patients over 65 in the United States, the amount of spine pathology that exists every year. And you can see year by year, it actually, all of the pathology goes up. The only one that kind of goes down a little bit is osteoporosis, and that's great, but it's probably a measure of our biologics and new medications that are helpful in preventing osteoporosis. But overall, the yearly prevalence of spine disease in these patients is about 27.3%, and that's just Medicare patients. It's not all patients. So the prevalence is probably much higher amongst the total population. But I think this is important because the population of people who are, or the number of people over 65 in our country at least, is going to continue to grow as the baby boomer population gets older. So we're just going to keep seeing more degenerative spine disease. Also, you can see the importance of knowing how to take care of these spine patients well by this graph. This shows two things. Number one, it shows the introduction of the milestone program in residency training. So once there were certain ACGME benchmarks for case volume and case logs, you can see that people were actually tracking the number of cases they were doing really well. And the other thing you can tell is that there's this light blue line that consistently goes up year after year. That's actually the number of spine cases that each on average program was doing of their graduates. And you can see that the other bars are at least a third of the blue bar, and those are all the craniotomies, the functional cases, peripheral nerve, vascular, et cetera. So the prevalence of spine, even amongst our residency trainees, is much higher than all of the other subspecialty groups, which just emphasizes that neurosurgery is really spine surgery. And the reality is postgraduate training is also changing. So this study was looking at all of the academic neurosurgeons up to 2023 or in 2023 that had some sort of postgraduate training, and they divided them also by residency start year. And you can see that as training gets closer and closer to current time, more and more people are actually doing postgraduate training. So the purpose of residency is really to get your clinical competency, prepare for independent practice. And some people, it seems like the majority here of people in academic practice, about 75% do a fellowship in something other than spine. And I think this matters for a couple of reasons. Number one, some of the postgraduate training is really required, right? Pediatrics, cerebrovascular, functional, you really have to do a fellowship in order to practice in those areas. But also, even though you do a fellowship at an academic center, as 75% of people do that are outside of spine, you shouldn't expect that all these people do zero spine cases. You still have to expect to be proficient at the cases that are going to present to your door, sometimes trauma that you can't necessarily pick and choose for in your subspecialty. So even when you're thinking about doing postgraduate training fellowships, I think it's really important for trainees to know that you may not end up doing exactly what you subspecialize in all the time. And so it is really important to make sure that your spine skills are at the best that they can be. So great, you signed a contract, you shook hands with your new boss, and now you're going to go meet all the really happy spine patients in clinic and then the hospital who are going to be so happy when you start to take care of them, right? So that's actually not always the case. So the old adage is being affable, available, and able. So being affable, meaning to your colleagues, being friendly and approachable, being available, meaning having a yes attitude, happy to help out, and being able is your technical skills. So you have all these three things and you think, okay, practice is going to be great. It's going to be straightforward. But it actually relies, at least in this country, more on how patients may perceive you, how they may understand the type of diagnostic testing that you're going to put them through, how they really interpret if you understand or feel their pain. So now more and more people are emphasizing patient communication is a huge key to the success in your early career. And not only is it just someone's opinion, but also we're being you're being evaluated on that. So people's likelihood to recommend score is something that hospitals will now look at in terms of, are you meeting their benchmark for patients saying that after they saw you they would want to recommend you to their friends and family. And that's something that may have not been there 10 15 years ago. The other thing is, anyone can get online now and look at your reviews or rate you. So reviews matter, the way that you communicate with patients matter, and how you make them feel actually matters. You can be an excellent technical surgeon, but if people don't like you, they will go somewhere else, and they'll never be able to see your great skill in the OR. So that's the sort of soft skill that you do need to know for neurosurgery. So not only is the IQ important, the training, your technical skills in residency important, but you also really need the EQ, which is the self-awareness and regulation, motivation, empathy, social skills, and in combination, that'll help with your success. So I'm sure, and I've seen other videos on the management of spine pathology, and this could be a whole talk of its own. But just to quickly give overviews on how different spine clinic is from cranial clinic. So I see both patients, and I've told Dr. Daudelet this multiple times, that spine clinic for me is way more difficult than cranial clinic, and that's because getting the right diagnosis is the majority of the battle here. So if you have a patient whose symptoms directly match with the imaging and it's perfect, and this is like a very typical case, they'd have a disc herniation and it's a perfect radicular pattern right where you would expect it, sure, book them for surgery, and it'll be very likely that they'll feel relief after the surgery. But what about this patient? Who has a cervical MRI and has just pain with abduction of their arm on the right side. And they really have more left-sided foraminal stenosis at C4-5. Can you say for certain that their right-sided arm pain and arm weakness is because of their foraminal stenosis? They also have a ectatic vert on the right side. There's a little bit of nuance and having to do additional imaging testing to figure out these sorts of questions, because the pictures don't always match with what patients will come in and tell you. So that's the importance of MRIs, CTs, and X-rays, using all the modalities to optimize finding the right diagnosis, doing a myelogram if needed in the cases of like arachnoid webs or patients who can't get a MRI. EMG is super important for patients who have potentially peripheral compression that may not be, it may seem like it's a radicular pattern, but could be more peripheral in nature. It's important to find that out before you do a surgery. And then a DEXA scan for bone health. It's really important when you think about complications and doing fusions on people who aren't properly optimized, because the pain of not having their bones fuse or heal properly after surgery can be way worse than the pain that they initially came in with. You also have non-surgical interventions, which I'll talk about on the next slide, as well as anesthesia pain management, which can be both diagnostic and therapeutic. Also learned that, very quickly in spine clinic, that not only do injections help you feel better as a patient getting an epidural steroid injection, but it also can tell you if you're targeting the right area. Is your radiculopathy getting better once you get that epidural steroid injection? Or did it not change at all, which could tell you that maybe this isn't where the pain generator is. So non-surgical interventions, these are the basics, but are often overlooked. So diet and exercise, obviously we talk about this all the time in spine health, reducing your overall body mass, a goal of less than 35, particularly for anyone who's undergoing a fusion surgery, and smoking cessation, a big one for preventing pseudoarthrosis. And there's also physical therapy, core strength, range of motion exercises are important. Most insurances will not approve a surgery if patients have not tried any of these non-surgical interventions, meaning even if you wanted to offer surgery, they wouldn't approve it if the patient hasn't done at least 6 weeks of physical therapy or tried any of the other lifestyle modifications. And then medications, NSAIDs, we don't love to use much, but muscle relaxants, gabapentin can be utilized in patients with radiculopathy. And then there's lots of adjuncts that I'm sure I'm even missing some here, but chiropractors, acupuncture, traction devices for cervical radiculopathy, TENS units, and bracing with activity. And then we have some anesthesia pain treatments. So epidural and transforaminal steroid injections, really helpful for patients with cervical radiculopathy, lumbar radiculopathy. It can help you, especially the transforaminal injections, figure out if there are certain nerve roots that when you give steroid to, if that helps with their pain. Medial branch facet blocks and radiofrequency ablation can be great for facetogenic pain. So, with axial loading, back pain specifically. And then the intraosseous basivertebral nerve ablation, which is a relatively new procedure, can help with flexion pain and those modic changes that you see on CT at the end plates of the lumbar vertebrae. So those are all some of the pain treatments that we send patients for frequently. And then you can also do spinal cord stimulators for patients who don't have clear pathology on their imaging, but still have a lot of pain. All right, so we'll jump into some cases. So the first case is a 55-year-old male with a history of hypertension, prediabetes, anxiety, and depression who presents with lower back pain for 1 month and left lumbar radiculopathy. His pain is characterized as sharp burning, and it travels down to his left calf with activity. He is intact on exam. So what would you recommend for someone who's only had pain for 1 month? It's a key. And then these are his images. For reference, the sagittal lumbar MRI is pictured on the top left, and then the axial corresponds to the L5S1 disk space. Feel free to jump in if you like.
Okay, I think everyone is muted, and usually we engage other faculty, but I'll go ahead. So usually patient comes in and you educate about the imaging, make sure that the image matches the symptoms, and we usually start with non-surgical treatments if they haven't, it's been only a month with low back pain and lower extremity radiculopathy, perhaps physical therapy, gabapentin as a medication, and perhaps also an epidural injection. That's the start point usually.
Great, perfect. So it's like he's done this before. So we did conservative management for 3 months with physical therapy, and he got an outpatient L5 transforaminal epidural steroid injection bilaterally with temporary improvement in his symptoms. So I saw him back in clinic after his acute exacerbation, and he had persistent symptoms. He said he brought his son to a water park, and going up the stairs was just excruciating, and so he really wanted something done for this. So we proceeded with an L4 to S1 MIS fusion with an L5 to S1 TLIF pictured there. And he really did have immediate postoperative improvement in his radiculopathy. And at 3-month follow-up, his pain was completely improved and back to regular activity. And so the reason I chose this case is because it's representative of finding the right diagnosis. So needing to do that epidural injection, also trialing conservative management. Sometimes it does help and can prevent or delay, having to do a surgical intervention. And he's a happy camper now. So The second case is a 33-year-old male with history of asthma who was admitted for back pain following a dirt bike accident. He was doing a wheelie and lost control and landed on his back. And so on exam, he was intact, but he has significant thoracic pain when he's trying to ambulate with a brace. So what would you recommend?
Okay, again, we usually engage our co-faculty
It's okay. I
hosts,
can also
and
continue.
then yeah, I mean, I'll take a crack at it too. I mean, uh, so we're seeing here a burst fracture involving, I can't maybe tell which level is this, but probably T7, T6,
T8, but
T8. Okay, so that's a burst fracture involving both columns with even you can see, I appreciate kyphosis on a supine image with the CT scan. The posterior elements are intact. The posterior ligamentous complex is intact. However, the concern here is the load sharing score. This is, probably 50% loss of vertebral body height. There's some splaying of the fragments, so probably the load sharing score would be around 6, perhaps even more. But given the, potential stability of this fracture, I'll probably offer a brace. But if the patient cannot tolerate ambulating because of the pain, because of the brace, then I will stabilize this fracture through a posterior long segment fusion.
yeah. So you're correct again. So I would, we talked to the patient extensively and tried having him ambulate with a brace, but he just couldn't tolerate it. He's also, 33, relatively young, and needed to go back to school. And so thinking about, how long would he need to be in a brace versus if we could get him, up and ambulating quicker with a surgery, we elected to go with this T6 to T10 fusion. And then post-surgically, he was feeling much better, discharged home. And I saw him for his 1-year follow-up and he's resumed his normal activity. So, not my typical bread and butter. I mean, it's a trauma case that comes in on call, right? So you have to be comfortable with that. But as someone who's mostly cranial, not always straightforward cases come in is my point on call. So next is another trauma. Dr. Khan raised his hand. Yes, Dr. Khan.
Let's see. Amna, can we unmute Dr. Khan, or we just let's see. Because we have the
Hey guys,
yeah, here we go.
Dr. Trybula, did you allow him to go back to dirt biking, or is that something he's never allowed to do?
He's allowed to get on a bike, but he's not allowed to do a wheelie.
Thank you.
You're welcome. But I'll talk about post-op care in a moment. It's a good question. So this is case number 3. This is a 26-year-old male who presents as a level 1 trauma after a tree fell on him while he was in a hammock. Really sad. He was extracted from under the tree, was unable to move his legs after the accident. So I saw him. You can see his exam listed below. So really completely no movement in his lower extremities. And he did have a sensitive level at T4. And so the MRIs are shown, T2 sagittal MRI stir, as well as a sagittal CT. Shows a 3-column flexion, compression sort of injury. So I don't know if we should keep calling on Dr. Daudelet. We're happy.
It's all good. Yeah, I will. I'll that's fine, right? Like that's the goal of the meeting, is to, discuss these cases and engage other co-hosts and faculty. But again, as you mentioned, any fracture with a neurological deficit is intrinsically unstable in an adult, right? Like, so any patient with a deficit, that's an unstable fracture, needs to be stabilized, decompress the neural elements and stabilize it. This one is a teardrop fracture, like a burst fracture with posterior element with the involvement of the posterior elements. So it's a 3-column injury. Typically, the board answer for this would be a 360 corpectomy and mirror it in the back with a fusion. But sometimes if the patient's young and patient has healthy bone, you can perhaps obtain by cortical purchase, you can get away with a corpectomy only and neck bracing. Now, so either a corpectomy of that level C7 versus a corpectomy and a short segment fusion. You're never faulted doing a posterior long segment fusion, but if the anterior and middle columns are involved, you'd rather reconstruct those for load sharing purposes and for better alignment. Plus, you're decompressing the neural elements. You can see here, there's, it's the dynamics of the injury. You can see that there's no severe compression, but there's cord signal change because of the magnitude of the injury causing the spinal cord injury. So
Great.
these are my comments.
Great, thank you. So as you mentioned, I did a C7 corpectomy and a C6 to T1 fusion. Thought about doing a short segment, mirrored fusion in the back, but he had great bone quality. Decided to just keep him in a collar for 3 months, and he actually went to rehab. Did have some increased sensation in his lower extremities, and then at his 3-month postoperative visit, he was able to move his left lower extremity, anti-gravity, just a little weak, and then his right lower extremity was still out, but have a lot of hope for him that potentially can get some strength back.
Great. I mean, the emphasis here is, right, like you see a patient with an AJ injury, just do it emergently or urgent basis. Don't give up. The sooner you intervene, the better the outcome, given you get clearance stuff, obviously, from the trauma surgeon. Sometimes it's a polytrauma and they're not stable enough to have an immediate intervention, but don't give up on patients with AJ injury. There's a lot of evidence that the sooner you intervene, the better the outcome. Dr. Khan, do you have a question? Can he be unmuted? Yeah.
Does he need a MRI as well to see if he develops some type of delayed complications? Do they get syrinxes from these, or is a CT enough? And if as long as the neuroexam isn't improving, you don't need to get an MRI in the long term?
That's a great question. I was not planning to get an MRI in the long term. I was going to just follow his exam. He's still within a year of his post-op recovery. So potentially if he stalls or if he goes back, if he worsens at all, then I would get an MRI.
I agree with that. The reason for a post-traumatic syrinx would be persistent compression or deformity. If there is, so unlikely it's going to happen with this person. Since the alignment is reestablished, the neural elements are decompressed. The setting where post-traumatic syrinxes occur is when you decompress and fuse patients in kyphosis, or just fuse them without a decompression. That's the setup for post-traumatic syrinx, because the circulation out of the spinal fluid is not reestablished with the decompression. So oftentimes, the patients that we see in a delayed fashion with a post-traumatic syrinx that happens and they start losing function cranial to the original injury are patients with persistent kyphosis or persistent stenosis. So the risk is low. We don't routinely obtain MRIs unless there's a new deficit, but looking at this patient, the risk is low. I've seen it in patients who, for instance, had a fracture dislocation, and unfortunately they were fused in that setting, right? Like without reestablishing alignment, these patients are at very high risk of worsening neurological deficit down the line due to a syrinx. Same thing with thoracic fracture dislocations, right? Like they attempt to reduce them, not successful, so they fuse them inside to do a little decompression. These are the patients who are at higher risk of syrinx, and the fix for that is more difficult because you need to reestablish alignment or extensively decompress neural elements to reestablish CSF flow.
Right. This is the 4th case, a 46-year-old male who presented to our emergency room with a complaint of bilateral leg weakness, low back pain, and progressive bilateral upper extremity weakness for 1 month. His exam is shown below, so hand grip and hand intrinsic weakness, as well as proximal leg weakness. He had diminished sensation, bilateral huff, and significant hyperreflexia. So again, some MRI shown. That axial cut is through 2, 3, 4, 5. And then also his CT, sagittal CT is shown. So what would you recommend in this case?
Okay, anyone from the audience wants to take a crack at it?
Dr. Khan?
Okay, it's still muted. So, all right. I mean, the pathology, nice to get a CT scan to roll out OPLL, right? Like, so you can see it skip OPLL, but at the level of the discs, there's no OPLL. Now, in terms of the evidence, right, like front versus back, meaning ACDF versus a posterior decompression fusion, long-term outcomes are the same. The good news about a short, however, when you're doing an ACDF on average, you're doing less levels fused compared to a posterior fusion. So when you're looking at averages like this patient, if you need to do a posterior fusion, you got to be probably a C2 to T2, or perhaps a, C3, you're, or a C3 to T1. However, a shorter option, shorter segments fuse would be a 3-level ACDF, 3 to 6.
Yeah.
So either or, you did a C2, that's great.
Yeah, so I did a C2 to T2 posterior spinal fusion with a C3 to 6 laminectomy. So his preoperative symptoms improved, and he was discharged to rehab. And at 3-month follow-up, he had continued improvement in his strength and hand grip.
Great case.
Okay. And the final case, so there's a lot of cases, but this is a 62-year-old male with back pain and leg pain for many years, worst when walking on uneven surfaces or using a push mower on a supposedly slanted surface. His sitting exacerbates the pain. He underwent physical therapy and epidural steroid injection initially, which improved his symptoms, but he still endorses back pain more than leg pain, gluteal pain that goes to the outer thigh and knee, otherwise intact on exam. So his representative images are illustrated here. So he's kind of multi-level degenerative disc disease, probably worst at 4, 5, 5, 1, as well as unfortunately extending up to 3, 4. He has pretty much no disc there as well. And he also has foraminal stenosis, worst at 4, 5, and 5, 1.
Yeah, I mean, you can be focal with this, but in all honesty, for me, that's probably a 3-level TLIF. I'm interested. What did you do to him? How did you manage him?
So actually chose to try facet blocks only because he had this significant back pain more than his leg pain, which did help at L5S1. And then he also got a transfemoral epidural steroid injection at L4-5 and L5S1 on the left. So he still had some improvement of leg pain, but it continued, and the back pain improved pretty significantly. So at that point, I did recommend an L3 to S1 fusion with TLIFs at L4-5 and L5S1. Did not end up doing a TLIF at 3-4. Symptoms did not seem to be originating from that level, but he had significant improvement in his leg pain immediately post-op, and his back pain resolved at 3 months.
Beautiful, beautiful result. Yeah, you don't have to TLIF every level for sure. The bottom level for sure, but the other ones, it's just if you have foraminal stenosis, you address it. But I agree, that looks really great.
Okay. All right, so back to the rest of the talk. So setting yourself up for success during training is something that's really important, and these are some things that I have learned in retrospect would have been helpful. So learning about other specialties, particularly anesthesia, pain, and physiatry. We don't really get much overlap with these specialties, at least at Northwestern, but these are opportunities that maybe we should seek out to try to get to know these providers and what they do during their clinic. And then also participate in spine clinic. I did do, some elective time and spent additional time in both spine and cranial clinics, but spine clinic is very nuanced, and there's a lot of different, strategies, ways to tackle spinal pathology. You can ask different spinal surgeons what they would recommend for patients, and you may get different answers. So just participating in a broad number of spine clinics and learn as much as you can from each provider. Understanding the role of preoperative imaging, labs, tests. It's easy as a resident and a medical student when you're walking into a room and you're in the operating room, for instance, and all the images are already up. You just pull them up from the computer. The patient's labs are already in the computer. All their testing has has been done for you. It's that's the stuff that you take for granted when you start a practice, is that now you're the person who needs to make sure that this patient has preoperative imaging, labs, and tests that are ordered that are appropriate. And, if you show up to the operating room and, the patient doesn't already have their, standing x-ray or their CT scan, that's really just on you then. So making sure that you learn the importance and how to order these tests and when to order them is something that has stuck with me in the beginning. And then finally, coding. Another little learned skill is how to properly code cases and knowing how to bill for reimbursement. At least in the United States, I know other places are different, but knowing how to properly assign codes and represent what you're doing in the OR is something that is a skill. And so there's a website called Coding for Clinicians. I don't get any kickbacks from them, but I use it quite frequently just to look up some of their coding. And then also there's the AANS resource for neurosurgical coding and reimbursement. But areas that residency will not prepare you for, so management of complications and just risks of surgery. So anytime we operate on patients, there is inherent risk, but beyond the basics of infection, bleeding, et cetera, doing a posterior spinal fusion in the cervical spine, getting a C5 palsy, how to even counsel a patient about what to expect after surgery with the C5 palsy, how long can they expect it to last, what are some things that they can do while they're waiting for their palsy to get better. Pseudoarthrosis, so things that you hope never happen to you, but definitely are prevalent in spine surgery, and having a patient come back with additional pain after their fusion with pseudoarthrosis, and knowing sort of some things that have been proven to help with that in the operating room, like graft material, bone quality, bone health, et cetera, BMP, if it's indicated. And then CSF leaks, right? Repairing CSF leaks, seeing patients after you get a CSF leak, headaches, how long do they last? Do you put them in a lumbar brace, or do you give them an abdominal binder? Just things that you don't necessarily learn about in residency, because these patients usually come back after the fact to clinic with issues, and that's an area that you don't get much exposure to. Follow-up and continuity of care. So at all of these different time points, patients will ask different questions usually. And it's not always as easy as like, oh, you're doing great. Okay, see you later. See you at 6 months. Sometimes people ask you questions that you don't expect. Like, I got a lumbar fusion, and when can I start running? Or when can I ride a horse? Or when can I start golfing? All the life things that you don't necessarily get taught in residency, that or in training in general, that people want to know because it's relevant to their life or their hobbies, et cetera. So that's another importance of going to clinic and really learning these things early on in practice. The inbox. So we have this thing called Epic, which is our medical record, and patients can message us directly through it, and being able to review these results in a timely fashion, following up with patients, responding to their questions. You don't have to do any of that in residency, and it's a blessing because it's a lot of work, but knowing how to respond and when to triage questions, when to take care of things is a skill as well. And then training and support staff. So, or training your support staff. So you'll have people that you'll start to work with, your outpatient team, your inpatient team, and you have to start to develop what your practice is going to look like, your preferences. Starting out, nobody tells you how to do that, right? You have to figure it out yourself, what works best for you. There's not necessarily a right or wrong way. Everybody practices a little bit differently, but being able to communicate with your support team and knowing how to run your practice really smoothly makes a huge difference. And really, when you see these these surgeons who are out here 20, 30 years, you just are amazed by how smoothly everything runs and how everybody knows what the surgeon wants. But that's because of years and years of practice. So getting that, your preferences and getting things early on to communicate with the team is very helpful. And other questions that people ask is, when do you become comfortable, or when did you become comfortable? I find that being comfortable is not really a good thing, because that means you're probably complacent, or you're not really thinking about things as hard, because everything should sort of make you uncomfortable in neurosurgery. So we're constantly seeing new things, challenging ourselves, doing new approaches, learning new techniques, right? Endoscopic surgery, robotic integration, MIS wasn't that common maybe 20 years ago. Now it's very common, but I actually think it's great to not be comfortable when you're practicing, because that means that you're really paying attention, right? Because any small surgery, even if you think it's small, can cause a disaster, right? It's not paying attention that usually leads to the mistakes. So being uncomfortable is okay. And now with this whole gentle parenting time, maybe people feel that they should never feel uncomfortable, but being uncomfortable, I think, is a good thing, versus, being unsafe. So you want to know the difference between the two, especially when you're starting out in practice, because you will be uncomfortable most of the time, and that's okay. So at least I was. But and lastly, mentorship. So I think this is really the cornerstone to success. And Dr. Donnelly is going to turn off his screen because he may cry at this point. But I am so lucky, because I just happened to have a program director, such as Dr. Donnelly, who I think everyone, if they are lucky enough to have someone like Dr. Donnelly in their life, is better for it, because he's someone who advocates for really everyone's success. But I was lucky enough that he decided to come to the Western region to become the director of neurosurgery out here. And I am one of the very few people that I know of that gets to work with their mentor from residency. And I gotta say that, uh, there are definitely, in the beginning of your career, you are going to say the words, "I've never seen this before," like probably hundreds of times, right? And that's why it is important to have someone like a mentor, because experience does matter. When I tell Dr. Donnelly, "Man, like, I've never had this patient have pseudoarthrosis before," he'll tell me, "Joy, I've seen 30 patients with this before, and this happens, and this is how you should manage it, and don't freak out." So experience does matter a great deal when it comes to especially complications, or patients who come in with weird presentations that you don't expect. There's also a great deal of case review and discussion for both inpatient and outpatient management. I think that's incredibly important, not to have an ego in this field, and just ask questions and be very transparent with whoever your mentor is, that you want some advice in these cases. And I think there's nothing wrong with that if you're doing it for the patient and getting the best outcome. It's I utilize Dr. Donnelly as a resource, probably, way too much, but I want to do the right thing. So, and then a person who's your advocate, right? So, especially when you're starting out in a practice, you don't want to be the person with the most expertise. You want someone who's been there longer, who's done things before you, and who can also advocate for you to build the practice that you want, meaning getting the resources that you need, having someone, even go out of their way to, make sure that everybody treats you as an equal partner, right? So having an advocate, someone who can stand up for you when you need it, and go to bat for you when you want to do things in the hospital that haven't been done before, or join committees, et cetera. There's a great deal of benefit that comes with having a really good mentor. So in conclusion, you do need to be proficient at spine surgery, regardless of your subspecialty in neurosurgery. You know, my interest is in cranial pathology, but I have learned so much about spine since starting a neurosurgery practice. The outpatient workup and management of patients in spine clinic is an undervalued skill, and making the right diagnosis is the first step and probably the most important step. Understanding the multimodal treatment of spine pathology is important, and getting to know the team well is especially helpful. So getting to know your anesthesia pain colleagues, physiatrists, PCP, neurologists, they will all help you. And then seek support and feedback with your diagnostic workup and management in the first year. There's no shame in that, no ego at all. Make sure you reach out for help and get a lot of feedback when you're starting out. And then finding a mentor that will advocate for your career is invaluable. And I hope everyone can find someone as great as Dr. Dadale. So that's all I have. Thank you.
Thank you so much, Dr. Trybula, and thank you for the extreme kind words, touching words that probably I don't deserve that much, but I tell you, you're a super special person, and we're supremely lucky to be working with you. And again, thank you again for the great words and the great representation. I mean, this is a great presentation that I hope people would reflect on it and learn from it, because that's the truth. That's the real life experience. You know, you learn a lot in residency, but once you embark on a career, it's slightly different, and you continue to learn as you're practicing. Most important thing is you got to learn from your mistakes and from your complications. And at the end of the day, you got to celebrate with your patients, but you got to suffer with them a little bit and be honest with them when you encounter when they get through something difficult, such as a difficult diagnosis or a complication. Again, this is a tremendous seminar, definitely one of my all-time favorites. No bias there.
Yeah, only because of the compliments, but
And then I'm going to open up. Thanks so much. And we got to open up to everybody. We still have 15 minutes. Anyone has any questions? We have the chat box that I can see. Okay, if there are no questions, that's fine. Thank you for the kind comments on the Dr. Walsh and Dr. Khan and Leonardo. Okay, so next week's host will be Dr. Andrew Grossbach, our colleague from the Ohio State University. He's also the PD there. I don't know if he has chosen a or spoken with a faculty participant yet, but I'm sure between now and next week on Twitter, on social media platforms, we will know who is the guest and what the topic will be about. Until then, I wish everybody a good evening and have a great night, and we'll see you next week.
thank you.